Thank you. Well, we're now ready to invite our first presenter, Michael Moody, who is Adjunct Professor from the University of the Sunshine Coast. Michael, before you start your presentation, could I please ask you to identify yourself and your organisation for the purpose of the public record?
I'm an Adjunct Professor at the University of the Sunshine Coast.
Thank you, Michael. Over to you.
Well, I've prepared a submission which has been provided on what I consider to be shortcomings in the NDIS market within Queensland. I suspect it's an issue in other states as well, and that issue relates to those people that enter hospital and for a variety of reasons become what's called long-stay patients within hospital, and in particular those people that are patients in hospital that are participants of the NDIS. The nature of the NDIS is one of being a market-based system where funding is provided to the participant to then purchase services within a market. That is an admirable goal. I think it's a good system, but it doesn't work particularly well for those populations of people that are in hospital because it requires, in my view, some facilitation of a market response to enable those things to happen, for those people to then exit hospital easily and in a planned way. Fundamental to the problem is that you have a group of people that have high complex needs that for a variety of reasons end up in hospital, and then normally they are change of life circumstances, so they may fall, have an injury, have behavioural issues. So their previous arrangements in terms of accommodation are often not satisfactory. So the process then starts to then try and find suitable alternatives for those people in the community. The process to date has largely been left to people when they arrive in hospital, and then the circumstances about how does one get them out of hospital. And there are many examples where people have been in hospital for extended periods, certainly over 100 days, and some people have been in there for periods a lot longer than that. The current arrangements within hospitals are that either social workers or discharge planners have responsibility to try and find suitable accommodation or suitable community options, and if the market hasn't been developed, i.e. there isn't suitable accommodation or support mechanisms in the community, then it doesn't matter what you do in the hospital environment. Those things don't exist. So my view is that government needs to facilitate the market, and we're not speaking about a mechanism where the Queensland State Government would fund those services, but it should have a role in terms of facilitation of the market. And by that I mean an understanding of, in particular, the numbers and the types of people that are in those facilities, and typically the most difficult people to place are those with an intellectual disability, comorbidities in mental health, have behavioural issues, typically require to live by themselves, and very high levels of support. Most current NDIS providers, because of the rollout and demand that they're facing, either don't know about those populations in hospital or are too busy doing other work to take an interest in that. The processes within hospitals are, there's complexity around the ability of Queensland hospitals to refer to particular providers in a market environment. There are a range of issues around appropriate tendering of those arrangements. For some services, Queensland Health Services do refer directly to providers, and others don't, and they use the Queensland Government tendering arrangements with a view that they are providing a benefit to a particular provider. That's all understandable, but I think it's an issue that needs to be resolved, particularly when it isn't state government money that's being used to provide the support and the accommodation arrangements. So a complicating factor has been with COVID, there's been certainly a tightening of the rental markets, and it's very difficult to provide rental properties through public real estate agents because they've immediately fallen at the bottom of the list. So when you have vacancy rates at 1% or lower, these folks aren't going to get a look in. I'm of the view that it's probably too late once people get into hospital. I don't think it's a difficult thing to do to find out what that cohort of people is within a community, so the north side of Brisbane, and there really should be a planned approach around identifying those people before they enter hospital and making sure that they have adequate support and that they have adequate accommodation, so that if they do end up in hospital, those arrangements are in place. It's a bit late once they are in the facility. So from a public health perspective, it's really stratifying the population into those groupings and taking those steps in a preventative sense rather than waiting for them to be a response because they're in hospital. The provision of information from Queensland Health, as you can appreciate, has huge challenges because the existence of the person in the facility is confidential. Because the data is difficult to obtain, and that's understandable, then the market response is very inadequate. So if you talk to developers that want to develop property for these folks, they're really saying, well, I want to know who the person is. I want to build something to their requirements, and I want some indication that they would, if they come in terms of a rental arrangement, that they're going to stay because the investments are quite high. So I think it's an issue that can be resolved, but the current arrangement is it doesn't work in that way. Had some discussions with QIC and some of the banks around, and in particular the Office of Public Guardian. A lot of the complexity from the accommodation provision can be removed if there was some scheme where the person, even if they're under the Office of Public Guardian or their family, could be assisted to purchase the property themselves. So that, because of the complexity of need, the SDA payments are quite considerable. So to front load a loan arrangement where those people could be facilitated to own the properties themselves would be a major advance, and that takes so you're not dealing with an investor that's looking for a return, you're dealing with a family member or the person themselves in terms of the design process, whatever. The other complication is the identification of the particular need or the complexity of the need of the person. I've taken interest in the NDIS since it started and have worked in Queensland Health and in intellectual disability facilities, probably showing my age, but when Challoner Centre was in operation in Ipswich, I don't think there's a consciousness of the nature of the need of these folks and the numbers of these people. I think NDIS is great for people that don't have an intellectual disability, that can manage the purchase of services themselves, whatever. This is a different category of person that requires specialist support, and I don't think there's enough research done on those particular needs and what the responses need to be within the community, and therefore the response that needs to be in terms of facilitation of the market. They're often in the health sector called frequent flyers. The disability group are a major component of the estimated 4% that use about 40% of public resources in terms of healthcare, and it's because they cycle in and out of the community public health. And if you get the basics like housing and support right, then there's often not a need for those folks to come into hospital. Or if they do come in, there's an exit path out. So and in terms of the provider community, unless they can be assured of some level of scale or volume, it's very hard for them if they have a particular, and the scheme encourages you to specialise in particular groupings of people. So you get good at that and you scale around that and you get your efficiencies. So if you've got a group of people that don't have an intellectual disability and you're providing support to someone in a wheelchair as opposed to someone that has significant intellectual disability, chronic health issues, whatever, that mix is very difficult for you to manage. It's at the higher end where you find that the provision of those civil providers is limited because they don't get certainty around the scale because of the investment required, so they don't do it. I've said in my paper that the Queensland Government should seriously reconsider the closure of AS and RS, the accommodation services, respite services. I still think it should be an NDIS funded service, but staffed by public officers that specialise in these categories of people and in particular transition from hospital. It will be a lot cheaper for the state to provide those services rather than keeping people in acute mental health facilities. So some facilities in the state, a third of their current mental health beds are occupied by people from the NDIS they can't exit. And I think that problem will grow over time because what you'll find is that providers that have clients at the moment that become problematic because of the issues within the NDIS, they will take them to hospital and they will withdraw service. If they can't get out of hospital, those numbers will naturally grow over time. And the state government will be picking up the cost, not the NDIS. There is a significant human rights issue that sits around all of this because I think it will be very difficult for an executive running a hospital to argue that given the NDIS that they can't exit people. So it raises the question then around, well, why is the person retained in hospital when on the surface, ignoring the complexity, that there is sufficient government support, significant government support for the person to live in a more meaningful arrangement in the community. I think that's a test that will come at some stage unless these issues are resolved. So there are issues around the provision of the facilitation of the market. There's issues around the nature of the person, the understanding those particular needs, and there's issues around the civil provision in terms of expertise to provide those services. The other areas that I think are important are in terms of support coordination. Generally, and I want to stress as a generalisation, Queensland public hospitals have sought to undertake the support coordination role internally by either social work staff or allied health staff. I think that has caused a range of issues that it does not facilitate the long-term placement of people in the community. The major one being is just that folks that work in Queensland public hospitals in those roles see the world from a deficit perspective, where it's an analysis of what you can't do, whereas the NDIS is very focused on what supports do you need to do the things you need to do. Those folks are not in a position to actually facilitate the market because of the issues around tendering and dealing with the market. I think it needs to be done at a more macro level because it does involve a multi-agency response. So they do the best they can. And I think at the end of the day, the pressure is to discharge, to get them out. So they get them out often into substandard accommodation, substandard provider. So I do think there is a need as part of the mix that there be some, to get around the tendering things, is that there should be particularly for health services, that there be a select tender process for support coordinators, that there be a select tender process for the SDA provider community, and there be a select tender process around the SIL provision, where the public hospital system enters a process with the provider about mutual obligations. Because one of the criticisms of support coordinators by hospitals is, A, the support coordinator doesn't know how the hospital system works, which is understandable, but also support coordinators don't work 24/7, or they go on leave. So if they've got a person they're dealing with, there's no obligation for them to act as, in a sense, as an emergency service. So hence the notion around the AS and RS being revitalised where those requirements would be placed. Because social workers within hospitals need to be able to call somebody 24/7 and get some service. But the cost to the public health system of the supporting of those people to operate internally is picked up by the state, whereas there's significant funding from the NDIS to do that work. And it's not necessarily an easy process where people are working across a mix of clients within a hospital environment to do that work. A select tender process, in a sense, is a pre-qualification exercise, because I think the public hospitals have a responsibility to make sure that they're discharging a person to an appropriate environment, a safe environment, and that, there's a variety of providers because it's a market. So I think pre-qualification will go a long way to ensure that people stay in the marketplace for these particular populations. So the OPG a lot of these folks the OPG is responsible for their administration. So the APG needs to be part of those discussions as well. So the support coordination is certainly a big area of deficit in terms of the mix, and that's part of the design of the scheme, that those things. The other area, and the NDIS, the disability folks don't like the term case management because it's health, but I've deliberately used one of the issues as being case management is that certainly a major complaint of people from public hospitals is that if the person comes in, they're discharged and they come back, there's no notes, there's no records kept about what the issues were or whatever. And an area that's often neglected is the health of the person. Given the nature of the population, they have health issues as well as disability. So you have a scheme around disability and you have a scheme that sits around health. There needs to be some efforts around bringing those two factors together. I think it is a goal of the NDIS, but for these folks to stay in the community, that needs to be resolved. So a case management environment and support coordination in the scheme is designed around a short-term, it's a facilitation, it's a training thing where people, once they get on their feet and they know what to do, they don't need the support coordination. I get that. But in terms of these populations, they're going to require that support for their lives because of the complexity of the issues that they're being confronted with. There may be some reduction in some reallocation of resources internally from the NDIS, but normally as they age, their need grows. It doesn't fall away. And I think that those design features within the scheme are because in the design of the scheme, these populations weren't necessarily understood and considered because they're away, they're normally in a hospital facility and not known about, but they are certainly eligible for that. And the case management environment should be owned by the person. So there should be a scheme where the case management environment, rather than being controlled by a provider, because the reality is there are multiple providers, so the case management environment should be owned, so the person or their family can say, or whoever's responsible for them, if you're providing services, you're going to use this particular platform and those things. So if they do come back in the hospital and they have had health input from whoever, then all of those things are in place. That'll go a long way to making sure that those people stay in the community. So, so putting all those things together, it is a considerable cost to the state government. There was a big push to get people out with COVID. I don't think that's worked very well. I think there is significant risk to the Queensland government in terms of substandard arrangements in terms of discharge out, particularly to providers that just don't have a skill set, because the market can just develop. This is very high needs, high complicated people. There's general dissatisfaction about how it works, particularly in the health community within public hospitals. But it's not an emergency department issue, so it's not a showstopper. It's a secret, hidden issue that is probably not top of mind to hospital administrators, because at the end of the day they get paid for that activity, which is a disincentive at one level. But it's certainly, I think, an issue for the state government. So if you're talking about markets, this is probably up there in lights in terms of an issue that needs to be addressed. So I agree with the thrust of the report, but I think it needs to focus on, as an example, the impact on that particular group. I think younger people in residential aged care is a priority issue for the NDIS, and it's being addressed by the Commonwealth, but this is clearly a state issue. So happy to take some questions and comments.
Great. Thanks so much. You've obviously touched on many issues that we've identified in the report, from the importance of accommodation, the role of support coordination, and issues around interaction of Queensland Government services with the NDIS.
Yeah, and other Queensland Government services amongst themselves.
Michael, could I ask you to cast your mind back to pre-NDIS? So has there been any improvement in accommodation outcomes for people with a disability at risk of long-term hospital stays since the introduction of the NDIS?
Look, I've certainly come across instances where it has worked. They're rare, but certainly when it comes together, and this is a general observation as well, not just necessarily this population, but in particular where the families have taken responsibility for the outcomes. Generally, families don't believe it, and that's, I think, an issue within the health system, where you're often when you talk to people in the public health system and you explain what NDIS participants are eligible for in terms of funding and also in rental assistance with SDA, I think it's fair to say that most people don't believe you, because of the nature of the clients they deal with and the difficulty in terms of trying to organise these things in the community. So there's a huge gap between most people that you deal with and trying to get them out of hospital, into social housing, whatever. They don't have family support. There's really not a lot. But then you come along and say, yeah, but for NDIS people, this is what's on the table. This is the goal level, and people don't. And it's also a particular issue within prisons. So yeah, they have their existing systems, but if you come along and say, yeah, but these things are available, they just don't believe you. So when it does work, it works wonderfully. It is a fantastic scheme. There are obviously issues with it, but the general principles are laudable. And really the issue here is that how do we, in the state, make it work so people access those things? And it essentially goes to collaboration, and it essentially goes to an understanding, dealing with that. What are the needs of this cohort? What do we need to do to then provide the services in a systemic way and to get them out of hospitals?
You mentioned the importance of support coordination, and our draft report talks about support coordination, the value that support coordinators bring to coordinating services. So for those that are in hospital waiting for discharge, do they have access to support coordinators through their plan? Has that been your experience?
No.
No.
And look, there are a number of reasons, and probably the most important one goes to culture. is that there was talk in the NDIS that there'd be levels of support coordination where people are qualified allied health professionals. That's dropped away. It's very difficult to engage with the public health system about a discharge of a client if you're not qualified. It's similar to doctor talking to doctor, and it's the same applies to somebody that's a support coordinator, probably with the best intent, that doesn't have those qualifications and doesn't understand the operations of the public health system. It becomes very challenging. So what the hospitals have done is that they've built that capacity internally, and that's understandable, to then try and exit people. But so the hospitals are for these folks generally, they're doing the applications for the plans. They're done in a particular way. They're focused on discharge. They're not focused on the longer term arrangement. They have hotlines to the NDIS because it's a government priority. But I think it's and the nature of tendering for support coordinators really is to put market signals that there's a need for this type of service, and that we want to engage with you, but we want some satisfaction that you know what you're doing, and there's some mutual obligation, i.e. that you'll be available. Without those mechanisms, it's very difficult for support coordinators to get into the swim. It's very difficult generally. Like I've worked in health for 30 years. It's very difficult even to get in the door to discuss the issue because of workload pressure or whatever, let alone have a conversation about the needs of particular people, and particularly if it's from a systemic perspective, where you say we want to build a system. Like what entry point do you come out as the social worker, as the director or whatever, because there's just a plethora of people that are in the public hospital system that's eligible for the NDIS. But resolving that support coordination issue is really important. The other complexity is that the generally most providers look to capture the client. So they come along with a deal and they say, come with me, I'll provide the SIL, I'll provide the house, and I'll provide everything else. And generally, the public health system is uncomfortable with that because that's not the principles of the scheme. So, and the providers are doing that. So there needs to be control over that so that there is market signals from the state that says, you engage with us, here's a fundamental rule of the system that these things need to be separated out. So they're separate providers for all the reasons the NDIS articulates.
In terms of the challenge that you identified around waits in hospital and the discharge process, interactions with the NDIS, are there any good examples interstate where these challenges are being addressed? Any good models that you can pinpoint, or is this an issue for hospital systems across the country?
Look, there have been different initiatives. South Australia ran programs to get people out, but I think those specific, and I can't talk authoritatively about it, but I think there are pushes at particular times around getting people out because they need the beds. Probably that's the wrong place to start. I think it's better to look at it from a population health perspective, where you look at the particular cohort, and it's not something you do as a one-off. It's got to be a longer-term arrangement, because the reality is that if you've got a group within a group within the hospital now, they are only a subset of a much larger group that are in the community that cycle in and out. So to think we'll do something for 12 months and it'll all go away is not correct. I think you're looking at a longer-term systemic issue, and that lends argument to the notion that there needs to be some government agency service that takes on those. If you can't get the market to step up, then you need to have the things like an AS and RS that still receives its funding from the NDIS, but there are asbestos people there. You have absolutely no problem getting SDA providers to do accommodation work. I don't think you'd have trouble with getting SIL providers to step up if they had that support. So there may be a process, a suggestion. Person comes out of hospital, they enter an AS and RS type environment where there's medium-term accommodation arrangements put in place. So there's a transition, and then because the behaviours of the person typically settle down once they come out of hospital as a more stable environment. Particularly if you know where the house is, it's far easier to then do a handoff to a market-based provider because they've been trained, they have the skill set. It's not that there's a shortage of money. I think there's adequate money there. And then there's some mechanism to keep an eye on, because you just don't hand off and let it go, but there's some mechanism so those folks don't end up in hospital for long periods, or if they do require health assistance, it's provided in another way. So it's a facilitation of the market model, and it's not a replacement of the market. But you've got to facilitate and step the market up.
And you mentioned in your earlier comments about the importance of case management notes or information sharing on the participants' health records and disability needs. Are there existing systems in place that could be utilised better, like My Health Record, or do we need new systems to be able to create that opportunity for information capture and sharing?
Look, there's certainly within the health, not specific to disability, no, because what the IT platforms in disability have really been essentially administration systems, and people may say, well, that's not right, but essentially they're there to record basic information so the provider can be paid. But certainly if you look at other areas in the health sector, if you look at the operations of people like Medibank Health Solutions that provide call centre technology, that are heavily based case management systems, where somebody like me that's getting on, overweight, has risk of cardiac issues, whatever, if you've got private health insurance, they will assign a case manager to you. They will give you access to GPs. They'll recommend. It's not a difficult thing to do. It's just not been applied to the disability sector. But it needs to operate at that level of sophistication, because disabilities has sat over here. It's about bringing them, into the fold. So it's not something where government has to invest lots of money in. These things can be purchased in the marketplace, but they just need to be applied to, to the disability sector, with a focus to provide a better level of care and support. And I use the word care deliberately because these folks do need care, and that the objective is that they don't come back to hospital. $2,500, $3,000 a day per bed day, over 100 days, over a year, really mounts up, particularly if you can get the funding from the NDIS in the first place.
In your earlier comments, you commented on the rehousing efforts that were motivated by COVID, and you expressed a view that you don't think that worked well. What didn't work well in that process? Obviously, people exited hospital, but what was the key challenge there, or what didn't work?
Well, they started in the wrong place. The objective was to get people out of hospital.
Right.
What I'm advocating. And look, and it's not a criticism of the people that were involved in those processes, but it's really about saying it's like many people I speak to about SDA. They come at it from an investment perspective. That's the wrong place to start. What you need to start with is the client and their family, and talk about what's the most appropriate accommodation solution for them, location, design, whatever. If you do that well and you do that properly, the money will flow. The investment will be a good one. It's where you start from the wrong place and you don't understand those fundamentals. So if your objective is to get people out of hospital, then that's your objective. It's not about a long-term solution in the community, ideally where the person owns the property themselves, which is quite feasible, because what you're trying to do is get them out of your get them out of that cycle where they come and go in and out of hospital. And that requires a different skill set, different approach altogether. And because what will happen is you get them out, something will happen, they just come back in around again. And so you just get this big cycle of people moving it. And that's where the 4% uses the 40% of resources. And the studies that people at Medibank have done in terms of those case management arrangements, there's significant returns in ensuring that people stay healthy and well and out of the very expensive acute ends of the market. And this is a population that does that. But the difference here is that you have a scheme that's well designed that can be utilised to ensure that they have a better life. And we're not doing that. We're definitely not doing that. And there's no silver bullet. And one of the things I've suggested in the proposal is that there be a pilot project. Let's give it a go. Let's work it out. Get better at it. And there's been some discussions with OPG about, because at the end of the day, for those people that they respond, they're the decision maker, and they're hamstrung in a sense, because unless the people calling them about what to do don't have the options, then those options are not presented, and we've got to get Michael out of the hospital. We've got a rental accommodation down the road, and we'll put him in there. But when you speak to social workers within the major services, they'll tell you they'll be back within 2 to 3 months. They know who they are. They know when they'll be back, and that's just how it works.
And so that knowledge that they'll be back, is that informed by the fact that they have a view that perhaps the accommodation that they're going to is not appropriate for their disability?
They know it's substandard.
No.
And not just accommodation, but in terms of the SIL provision, but in particular the behaviours of the person. So it's not a criticism of the SIL provider or whatever. It's the work that's required to match the needs of the person to a specific arrangement, and that's a feature of this particular cohort. This is not the same with somebody that's come in the hospital that's had, say, a motor vehicle accident and they need a wheelchair and they go out. That's a different environment. These are people with very complex needs that are in our systems, but we don't have the technologies in terms of, we have the technology in understanding and diagnosing the issue. We don't have the technologies in the provision of the service mix in terms of response that's best for them. You only get there through the case management environments where you trial a particular thing, this is what you need to do, and you then learn, but there needs to be some group that embodies that knowledge over time. And market responses don't normally do that. That's because the market has different sets of agendas. But for these groups, if you want to keep them out of hospital, well, the alternative is you say, we're going to keep these people and we'll build facilities. They used to be called institutions to house them, and that will be the solution. And we all know what happened to the institute. But there's certainly been discussion about that. It's not dead and gone, despite the NDIS. That's still alive because what do you do? They can't stay in because the opportunity cost for the health system is significant. Because those people are sitting in those beds. There's only so many beds. Then you can't treat other people who probably have a good chance of rehabilitation and getting on with their lives. So it's a serious issue.
Michael, thank you very much for your written submission that we received yesterday and your oral submission this morning. Clearly the issues that you raise are within the terms of reference of the inquiry, and we're particularly interested in the accommodation connection, both within the NDIS and the issues that you raised around the importance of appropriate accommodation. So thank you for your participation today, and we might close your session there.